Hello, I'm John Foster, and I'm a medical doctor who does Social Security disability exams. Today, I'm going to talk about taking the history of the patient with a special focus on detecting signs of functional illness. As usual, everything I say will be based on my own experience and research and does not represent the official opinion of the Social Security Administration or any other governmental or medical body. There are several important differences in assessing a patient for disability versus the normal history and physical exam we would do when seeing the patient either in primary care or for a specialty consultation. What we're trying to determine is what can the patient do, what can't the patient do, and what can they do but with difficulty, and how much difficulty as it relates to work-related functions. And we're only interested in work-related functions. When I review patients' records before my exam days, I often see that one of the reasons a patient has listed for their disability is erectile dysfunction. That may be a serious problem for the patient that causes them great distress, but I have yet to meet a patient where that was an essential work-related function. To recap, the standard function Social Security is interested in is the patient's ability to sit, stand, walk, lift, carry, handle objects, speak, travel, understand, remember, concentrate, persist, interact socially, and adapt. You'll find that list in the description below. The second major historical difference is that in a disability exam, we're focused on the here and now. In a normal medical history, we want to get the entire history of the illness. When it began, what were the initial problems, how did it progress, was there any treatment, response to treatment, etc. All of those are of peripheral importance in a disability history. What we want to know is where is the patient now? What problems does their illness or injury cause for them now as relates to their ability to work? One problem I encounter is that many patients want to talk about the past, and I often try to focus their attention by asking them, if you were to be offered a job today and told that your start date was tomorrow, why couldn't you accept that job? In medicine, we tend to separate the history from the physical, but in reality, that's not exactly what we do. We're examining the patient's physical abilities from the moment we set eyes on them. And usually the patient continues to give us historical information while we're examining them. The office I work in has a plate glass window that faces the parking lot, and sometimes I actually see patients driving up and getting out of their vehicle. I find that very helpful. I can see, does the patient get out easily and walk without any difficulty to the clinic? Or do they have trouble getting out of their car? And do they have a gait abnormality? Last month, I saw a man driven up as a passenger in a pickup truck, and when he got out of the truck, he was shirtless. He put on a t-shirt in the parking lot, raising his arms up high over his head. Then, for some reason, he took the t-shirt off. Then he put it on again. He'd raised his arms up like this 3 times before he entered the clinic, and he did not know that I was observing him. During the physical examination, I asked him to show me his range of shoulder motion by abducting his shoulders, and he got his shoulders to this position and then said he couldn't abduct them anymore because it was extremely painful. I usually say that I want at least 3 positive signs of functional illness before determining that the patient's problems are functional. But this is one of the rare situations in which I only need 1. This man was clearly acting. Now that doesn't tell me the motivation for his acting, but based on the rest of his presentation, I feel that he was malingering. Commonly, I'll greet the patient in the waiting room and then walk them back to the exam room. I've found that the way the patient responds to an initial "hello, how are you?" is quite revealing. As I mentioned in my previous video, normal humans, and in fact all mammals, suppress outward signs of physical emotion. So a patient who gives a histrionic description of distress, or sighs and moans and groans in a dramatic fashion when walking the brief distance to the exam room, is likely at least partially functional. I certainly see plenty of severely disabled patients, but their response to "how are you" tends to be the simple "fine," and although they may struggle to walk from the waiting room to the exam room, they don't tend to make a lot of noise about it. Once the patient arrives in the exam room, I observe carefully how they sit down in a chair. Do they do it with ease, or do they do it with difficulty? Often the patients will be carrying something in their hands, for example, a woman with a purse, and usually they will bend over and put their belongings on the floor. Again, I observe this carefully. Can they bend over with ease, or do they have difficulty? If somebody can bend all the way over to 90 degrees to put their belongings on the floor, but when I ask them to demonstrate their lumbar range of motion by flexing forward, and they complain of severe pain and inability to do so, then their problems are not physical. A couple of things I tell all patients before starting is that I am a medical doctor. We're going to be doing an exam for Social Security to assist the Social Security Administration in the patient's disability evaluation, that I do not make the final decision on their evaluation, and that it is not an examination to treat them. In fact, there is no doctor-patient relationship. I then ask the patient to tell me why they can no longer work. I'm sure everyone watching this video has been ill and/or injured at some point in their life, even if it was a common cold or a sprained ankle. And we know that illness and injury cause negative emotion. We are sad because we're not feeling well or we can't do our normal activities, and we tend to worry. Will we make a recovery? Will we need to see the doctor? What all do we need to do to get well? Patients tend to express some of this negative emotion in their history. I'm alert for patients who describe their illness and injury and seem to be pleased or proud because of it. That's not a normal reaction, and it always suggests to me that there is a functional component. Another situation I see from time to time is the helpless patient, all-caring caregiver dyad, a form of folie à deux. The patient is the dominant personality and usually has a functional illness which they blow up to enormous proportions. The caregiver is convinced that the patient is terribly ill and does everything for them. Usually in such a situation, the caregiver wants to do all the talking and answer all the questions. That can be a difficult situation because I have to assess the patient's mental and social functioning. And sometimes I have to flat out tell the caregiver that I need the patient to answer all the questions unless they absolutely cannot. On the flip side, sometimes I see severely disabled patients who either have aphasia or memory or thinking disorders, and in that situation, having a family member or friend to assist with the history is invaluable. People who have problems with cognition or memory tend to be ashamed or feel bad about it. On the other hand, people who loudly announce that they have cognitive problems or impaired memory tend to be functionally ill. I'm always impressed by the patient who tells me they can't remember anything while they're giving me all the details of the past 10 years of their disabling condition. Another clue to functional illness is the use of excessive modifiers in describing the problem. Think about the last time you had a stomachache. It's kind of hard to describe the pain, isn't it? When patients talk about their pain being terrible, excruciating, the worst you could imagine, and other histrionic descriptors, it suggests that their problem is functional. Think about the patients you've seen who you know had severe pain. For example, women in labor, patients with kidney stones, or patients with fractured femurs. Did they lie on the table and tell you that their pain was excruciating and the worst they could possibly imagine and hell on earth? Probably not. If anything, they probably just said that it was bad. Some patients will have had their problems originate from an automobile or other sort of accident. And in those situations, I want to gauge how severe was the accident. The routine questions I ask are, did the patient require hospitalization, or were they treated in the emergency room and released? Did they require surgery? Did they break any bones, or did they require stitches for lacerations? An interesting fact is that whiplash patients take months or years longer to stop complaining of pain compared to patients with cervical spine fractures. And I've been impressed by how many patients were in quite minor auto accidents 10 or more years ago, and yet feel that they have disabling injuries that prevent them from doing any work. Another fact to keep in mind is that wounds heal. That's a basic principle of medicine. For example, I frequently get patients complaining of pain from healed long bone fractures that occurred years ago. Now, certainly patients can have problems with such things as non-union, or they can have a fracture that goes through a joint causing post-traumatic arthritis. But a fracture of the mid-shaft of a long bone should be healed within a year and pain-free. As a personal example, I fractured my left clavicle in 4 fragments in 1995. Initially, the bones would crunch and move around if I moved my shoulder at all, and I had some pain. But after a year, it was healed solid, and now, no pain at all. Another of my tenets is if the patient describes a problem that is anatomically and physiologically impossible, then it cannot be due to physical illness. For example, I certainly see patients with low back pain that shoots down one leg, occasionally down both legs. But I had a patient who told me their low back pain shot up to the top of their head and then to both eyeballs and felt like an explosion of glass going off in their head. That's physiologically and anatomically impossible, and therefore was due to psychological rather than physical illness. Finally, I'm in my 43rd year of practice, and as such, am kind of a historical relic. And I've seen a lot of things come and go in medicine. What I would tell young physicians is that you are there to assess the patient, not to assess your laptop. Staring into a laptop is the worst way to make a patient's diagnosis. I know that electronic health records are now required. I think they're an abomination before God and man, but I can't change that. But I would encourage you to at least glance up from your laptop to the patient frequently while you're taking the history. And always remember, if it happens, it's possible.